And thank you to Marilyn and Tony and the committee for the invitation. And I've learnt a lot already today, which is what it's about. It's this two-way education, I think. And I've worked yesterday as a pharmacist. I still practice as a pharmacist. I have a pharmacy, amongst other things. And unfortunately, it is one of those conditions where health professionals don't know a lot about it. So it's important for people like me, to come along and learn. So I learn just as much or more than you're going to learn from me. Because the drugs that I'm going to talk about aren't nearly as exciting as the 3D printing and the neuropathics, and it's pretty dull, really, the drugs that I'm going to talk about. Anyway. And most advances in drug therapy have been it's the cancers, the monoclonal antibodies, some of the great breakthrough drugs we've had in cancer therapy. And the irony of that, and something I might talk about if there's time at the end, is some of those drugs actually make CMT worse. I don't know if you're familiar with this. Some of those drugs, which is a bit of a dilemma of some of the melanomas, some of the breast cancers, some of the very new expensive MAB drugs, which are now PBS listed, very expensive agents, but do prolong quality of life in melanomas, advanced melanoma, advanced breast cancer. They also do have this potential to cause neurotoxic effects and can actually worsen CMT. So that's a real dilemma for patients who may have breast cancer, for instance, and they have CMT. Anyway, we can talk more. There are some other older drugs that are like that, amiodarone, a few others, but it's just a peculiarity that some of these very wonderful new drugs for cancer therapy actually have been shown to worsen a number of neurological conditions like CMT, or have that potential to do so. So I'm going to talk about, I'm focusing on pain, and even more so focusing on a special one form of pain, neuralgic pain. So just bear that in mind, and I'll repeat it sort of as we go through. So it's really focusing on neuropathic or neuralgic pain, which is common in CMT. But we need to bear in mind, and Josh mentioned hip pain. Often people with CMT have musculoskeletal, other forms of pain as well. And the management of that can be quite different. So, and I'll allude to that a few times. So the pain management there are drugs that work best for the neuralgic sort of pain, and then there are the more conventional analgesics for the typical musculoskeletal pain, and often the two may need to be used together if you have both of those types of pain. So chronic pain, major problem. That last slide showed that, coming down a bit to, in particular, neuralgic pain, or nerve pain if you like, neuropathic pain, which, as the name implies, occurs when there's some sort of damage to nerve pathways. It can occur in a number of conditions. It can be due to compression. For instance, in patients who have tumours, cancers, there may be compression from the tumour as it gets larger on nerves. Or it can occur, for instance, commonly with lower back injuries, disc injuries, prolapses. Again, there may be some compression on a nerve, and that may continue beyond the actual acute pain from the back prolapse itself. So those sort of issues, it can occur then also with a number of neurological conditions, including CMT. As part of those conditions, MS, multiple sclerosis, for instance, it's very common. And it can occur post-stroke. Some people who have stroke, following that they may develop neuralgic pain. And one you may be familiar with is shingles, after shingles, where about a third of people are left with what is called post-herpetic neuralgia, or neuralgia that follows herpes zoster or shingles. And that can be quite painful, and it can continue on for a number of years. So a number of sort of conditions, all underlying that presumably is some damage, some impairment of nerve function and pathways that causes these abnormal sensations, particularly pain, which, and you probably experienced some of these symptoms, whether through CMT or through other causes of these types of pains. The stabbing sort of electrical can be very sudden pain, very sharp, or it could be pins and needles. So it varies, but it's that's a typical nerve pain where it really, in its conduction of the pain impulses causing this shooting sensation, this almost electric shock type sensation quite often. So in terms of neuralgic pain, we said before pain in general. Of that, then neuralgic pain or neuropathic pain is also very common then. So about 7 to 8% of all adults, because of the various reasons that can produce this type of pain. Diabetes is one that I haven't mentioned, where with particularly long-standing diabetes, particularly if it's unfortunately not well controlled, there is nerve damage, what we call autonomic neuropathy. So nerve damage, very common in diabetes. And then these patients also get neuralgic pain and can also, as Garth was alluding to earlier, often end up in that situation where they have impaired sensation, numbness, poor circulation coupled with that, leading to a high risk of ulcers and potentially gangrene and amputations as well. So diabetes stands out as one particular group. HIV is another group where this sort of nerve damage very common, and some of the drugs in that case can also exacerbate that. And one of the main points is that the drugs that they used, which we'll go into, they tend to be different drugs. They're not the conventional analgesic drugs, which don't work so well for this sort of nerve pain. They're not as effective. And that includes even the strong opioids aren't as effective typically in this type of pain compared to other forms of pain. So we've mentioned some of these. These are some of the common conditions associated with neuropathic or neuralgic pain. And there, as we've implied, they're things where there's some underlying damage, whether it's a progressive neurological condition like MS, whether it's something like or diabetes, or something more acute following a herpes zoster infection, following shingles, or following a stroke. But they're some of the common sort of ones. And the lower back these days too. The lower back's a major, just the volume of people, the number of people who have prolapse and disc injuries, etc. And then a proportion of those are left with sort of shooting pain down the leg, etc., neuralgic pain. Coming back more closely now to CMT, there hasn't been, I've sort of looked into the literature, not a lot published in terms of pain, how often and what types of pain are present. This is something from 20 years ago. I did talk about neuropathic pain, saying it's a significant problem and seems to be similar in many ways to, for instance, the neuropathy, neuralgic pain that the diabetic patients. And that's a typical sort of thinking, that it's one of those neurological conditions, and the pain mechanisms are probably similar, and therefore the treatment should be probably similar. So that thinking is still the current sort of approach. So this was a study 20 years ago, a survey just looking at pain in patients with CMT, perhaps biased a bit by the response rate, in that people who did have pain were perhaps more likely to respond. But even so, you can see there's certainly high rates of pain. Some of that, again, may be musculoskeletal rather than, or in addition to, nerve pain, neuralgic pain. And that's been one of the sort of debates or the issues about what is the underlying pain mechanism. It does seem to be a bit of both. It may also depend on the subtype of CMT as well, the different sort of actual cause or etiology mechanisms. But it's just important to bear in mind that often there is a musculoskeletal component as well, which might need paracetamol, for instance, or anti-inflammatory drugs, which tend to be not so good for not so successful for neuralgic pain. So this was a more recent review which talked about that, and it did they did sort of suggest most cases probably involves neuropathic or nerve pain, and again just referring to perhaps it's similar to the other common sort of neuropathic pain syndromes, such as in diabetes or post-herpetic, the post-shingles, and it occurs with a high frequency. So just making the point, I've made it already, maybe joint aches and pains as well. The approach there would be different. That would be the traditional analgesics, always starting with paracetamol, which tends to get forgotten. Paracetamol should be generally continued as well as other things are added. It shouldn't be replaced. So paracetamol is one of those ones that often get overlooked, but it is important as a sort of baseline pain management, particularly if it's musculoskeletal. Another important point, which is perhaps self-evident, is that the drugs are only perhaps a small part of what should be the overall treatment. The physical therapy, also in psychological-based therapies, cognitive-based therapies or CBT, exercise, we've heard already, very important. These are perhaps more important than the drug therapies. The drug therapies are just part of the equation. They should never be the whole solution. We're talking here more typically the whole changing sphere of pain management worldwide now. You would have heard of the opioid epidemics in the US, the very high rates of opioid use in Australia, which are not far behind the US. A number of reasons for those problems, one of which is not using multi-modes of other therapies to manage pain, and people ending up on strong opioids long term. The evidence for the benefit of those drugs long term is very limited. They might be very successful short term, but not so much long term. Certainly carry some risks. So specifically then honing in on the nerve type pain, and there's consistency internationally and in Australia in terms of the drugs that should be used. Basically there's a choice, first line there's a choice. I'll talk about each of these. Amitriptyline, duloxetine or Cymbalta. If you want me to mention brand names, we can do that. And then two other anti-epileptic drugs which are very similar, pregabalin and gabapentin. So they are the major sort of options, the first line type of options, if you like. Noting that they're all drugs not developed specifically for pregabalin, a bit different, but generally not developed specifically for nerve pain. They've had other uses in life, whether for depression or whether for epilepsy. Because their pharmacological properties, however, in that they alter electrical conduction, whether that's in the brain, conduction of the neurons, say in epilepsy, where they tend to stabilise some of the neurons which fire off easily in patients with epilepsy and cause seizures. So it's the same sort of mechanism where they stabilise the nerve cells, impede sort of abnormal electrical conduction and pathways. So it's not surprising in a way that these drugs are also useful for nerve type pain, but often wasn't their first intended use or major use. So that's just showing that in a table form as well. The international guidelines, so the same group that we meant, the three at the top there. I'll talk briefly about some of the second line options which might have particular roles, but more so if it's very localised, if it's just in one area, things like the patches and the creams, etc., might be useful. Not so useful if it's involving a whole leg or limb, not so useful then. And then really the message is that these days the opioid type drugs, the oxycodons and those sort of drugs should really be a last resort, and perhaps supplement the other first line options. Okay, and a bit like paracetamol I've mentioned already, the one that tends to get forgotten all the time is poor old amitriptyline. Very old drug, very cheap drug, inexpensive, therefore not promoted heavily by pharmaceutical companies, etc., to GPs, etc. So this is an issue where it does get forgotten, but it is actually the first line recommended therapy for neuralgic pain in Australia. Starting, like another message I'll talk about, is starting and in low dosage, gradually increasing, which is an important lesson with most of these drugs. It has to be a very gradual process. Can take 12 weeks to see if they're going to work or not. Which is what that slide's saying. You've got to give it a go over about 12 weeks because especially when it takes nearly half that time perhaps to get the dose up to a stable or therapeutic dosage. So these aren't drugs they're not analgesic in the normal sense. They're not painkillers you take for a toothache or headache. They are drugs that are more preventive. They will work, it takes them weeks to work. They're not going to work acutely for sudden pain. So you've got to, for that reason, it's a matter of A, building up the dose slowly to try and avoid side effects, and B, just giving it time to see if it does improve the pain longer term. They're not sudden painkillers. Mixing, we'll talk a bit about combining some of these. It's not tends to be done. The combining is more with the regular analgesics like the paracetamol plus one of these, rather than using several of these drugs together, these particular neuralgic pain drugs. Okay, so same message here is some patients needed, in fact the same in that way with depression, when these drugs are used for depression, which is a major problem in that context with people are severely depressed. These drugs take at least a month or two to have their full effects in depression. And it's the same here with neuralgic pain. They don't work quickly, it takes a while. They change the biochemicals, that takes time, and that changes the electrical pathways. So that doesn't happen instantly. It does take weeks, especially as the dosage has to be built up gradually. Another big issue I've sort of mentioned with the opioid epidemic, etc. The whole thinking about pain management has changed radically. What I learned as a student years ago, it's all different now in that it used to be all about pain-free, totally controlling the pain, totally avoiding the pain. That sort of approach now, that's not the thinking these days. It's more about tolerability of pain and ensuring the patient still is able to fulfill, have work or have quality of life, not necessarily being pain-free. That tends to be an overly ambitious and an unrealistic expectation most of the time. And that all it does is perhaps drive overuse of some of those drugs like opioids, chasing that dream, if you like, of being totally pain-free. So that sort of thinking's gone out the window these days. It's more about having tolerable pain, reducing the pain to acceptable levels that you can perform activities of daily living. Cannabis, cannabis use is now in Tasmania. We can use it mainly for epilepsy, severe epilepsies. I'm one of the members on the committee in this state which looks at approving those submissions for treatment for cannabis. So that's a topical issue, and lots of people want to use cannabis or try it for different conditions. For this sort of neuralgic pain, the evidence isn't particularly great, to be honest. It's strongest in multiple sclerosis for spasticity and pain associated with that. Even then, the evidence isn't phenomenally great. So cannabis for this sort of pain, general thinking at this point in time is not a big role, not something we'd encourage. Okay, so a little bit on the drugs that we've mentioned, and the print here might be a bit small. I've done some handouts. Unfortunately, I under anticipated the audience, Marilyn. So there may not be enough handouts. But we said these are the first line drugs. These old, what we used to call, or still do call, the tricyclic antidepressants. Amitriptyline is the sort of standard of that, but there are several ones, nortriptyline. So these are all one group, if you like. But amitriptyline is the one that has the most evidence. So it's the one that tends to be used. Key things to point out again, this gradual increase in dosage, up to about 100 milligrams per day. Higher dosage is used in depression. Lower dosage, only a lower dosage is required in this context. One of the issues is it tends to cause drowsiness, which can be beneficial. It can also help with sleep if taken at night. So it often is taken at night. But it can cause the sort of drowsiness and can cause things like dry mouth, especially to start with. That tends to subside again with therapy. So it's again an issue of encouraging people to try and stick with it, see if some of those side effects reduce with time, and see if the efficacy increases with time. Okay, so there is some patience required. It's not suitable for all patients. I think someone mentioned prostate conditions this morning. For instance, that might be an indication in large prostates where amitriptyline may not be used because it can cause some bladder, urinary retention problems. So there are some people who, for good reasons, wouldn't take this. But generally, the message is this should be the first line therapy. It's just not promoted as such. The ones on the right are very uncommon, but again, people with heart arrhythmias, it may not be the best drug to use if people have heart conditions or arrhythmias. I won't go into this in detail. It's in the handout. There's a bit more of an information sheet on the drug, but it's the same sort of messages starting low, go slow, etc. Give it a fair go. Second line, and one some of you may have taken or have heard about, perhaps because it's used a lot these days. It's on the PBS, Lyrica or pregabalin. Relatively expensive, but covered now by the PBS, which is why it's used a lot, I guess, and it's promoted very heavily. No evidence it's any better than the one we just mentioned, amitriptyline. Perhaps less side effects, but not always. It can cause, again, drowsiness in particular and sort of dizziness to start with. Some people can get weight gain. Some people can get fluid retention. If they've got heart failure, it's not good, can retain fluid. So it does have some issues, but usually pretty well tolerated. One of the advantages with this one, and it's about the only one you can increase fairly quickly, relatively quickly. It's a fairly standard dosage, there's limited leeway. It can be ramped up pretty quickly. So that's one of the reasons it tends to be used a lot, apart from its heavy promotion. Extensive promotion. The older version was gabapentin, which was never PBS listed, so therefore was fairly expensive. That's the reason that largely it hasn't been used a lot. Pregabalin is just a modified chemical based on that. It's slightly different, and the company did apply for and did get PBS listing for that, but not gabapentin, which has some advantage nowadays in that it's relatively cheap. There's a whole lot of generics of gabapentin now, so that means it's relatively cheap these days. One of the issues it did have was this dosage increase. So again, it has to be very gradual. That probably led to some issues where people were cranking it up too quickly. Patients or doctors were probably increasing it too quickly and getting the sort of sedation and dizziness from that, which is the advantage of the pregabalin, where you can sort of do that and perhaps not have any issues. But it's still an option. Still an option, even, and some people who find pregabalin doesn't work, gabapentin may work. So It's not always clear cut who will respond to which of these. The other group, the other one in this sort of top tier, if you like, duloxetine and a similar antidepressant, similar mode of action, venlafaxine or Effexor, which you may have heard about. So predominantly used for depression, but also pretty good evidence for use in neuralgic pain. Again, the same story of increasing gradually. One particular issue with both of these is stopping them also has to be gradual. Some of these antidepressants in particular can cause withdrawal problems if they're withdrawn too quickly. People can get shaky and sort of dizzy and they feel not quite with it. They're almost in a different world or zone. So they have to be withdrawn slowly if they're reduced. How are we going, Peter? Okay. Then there's these sort of second line, not so much of a place in therapy, and a couple of those are applied topically. So they're not all that useful if the neuralgic pain's fairly generalised in a large area of the body. So there's lignocaine patches, Versatis, which aren't covered on the pharmaceutical benefit scheme. They're quite expensive. I think from memory it's about $5 or $6 per patch. So they're fairly expensive, would only be in people who have pretty localised neuralgic pain, can sort of point to the areas and you could apply the patch locally. A bit similar, capsaicin, there's some compounds that have patches, and there's Zostrix sort of cream of that as well. Again, reasonably expensive, really for more localised pain. Botox, I think Josh mentioned briefly. Botox is sort of an option for people more with muscle cramping and pain and spasm, that sort of pain. Botox injections are an option. Opioids, won't say a lot, so these should really be just the sort of last resort, the tramadol, the oxycodone type opioids, because of those problems that they have. Combining them, there's just one condition you should perhaps know of called Serotonin Syndrome, where several of these, if combined together, can cause quite abnormal behaviour, fever, mainly confusion or sort of disorientated. It doesn't occur commonly, but it can in severe cases be fatal, so it is something to recognise, even using tramadol with some of these. Tramadol has similar properties on serotonin, so it is something just to be aware of when combining several of these groups together. Okay, so to finish with key issues, and in the handout there's a bit more on this. I've tried to emphasise that the drugs aren't the whole story. There's a whole range of other therapies that are equally or more important. There's also social support, social networks, pain, chronic pain networks, internet, etc., such as this one, Chronic Pain Australia, support from other individuals going through the same sort of processes. So, in conclusion, just to wrap it up again, neuropathic pain, fairly common because of a whole host of conditions, including CMT as one of those that can cause this. The problem is it doesn't respond so well to the typical analgesics like paracetamol. Does require generally these more specific neuropathic pain medicines. One of the issues we've said about, though, is being sure that what are the causes of pain. If the person has osteoarthritis or has musculoskeletal pain, then in addition to neuralgic pain, they'll still need the older anti-inflammatories, so paracetamol potentially. That's probably what that slide is saying. We've gone through what are the ideal choices, just bearing in mind there may be other contributors, and then for some of the other drugs may need to be also used. And I've made the point earlier, CMT, sort of that underlying assumption that it's like the other neurological conditions and therefore the treatment for pain should be similar. So the evidence base, if you like, is a bit vague. I think that's it, Peter. On time. Thank you.